thank you all for being here. And thank you for being patient. You all could tell in the audience, I kept inviting people to the meeting.
Yeah, you did.
Well, they all came, and they were all important. The CMS settings reg that Susie was talking about that was released last week was historic, and it really was tremendous. And when I was there when we had the opportunity to brief the secretary about the reg, I've talked directly to Cindy Mann, who's the head of the Medicaid program. Watching the federal government move as a longtime state government person is interesting. It's slow, but this was a leap. I mean, you really could feel that by giving this guidance in the setting regs, we were really going to make some changes, and a lot of work to do, but that was big. We have just wonderful relationships with our partners at CMS, and so I just want to thank you all for being here and the follow-up work that we will all find now to do together so clearly, because we were here all day, so you just have half a day of notes. So there were a couple of other people here today that I wanted to acknowledge. Dr. Tom Eads, are you still here?
Yes.
Where are you? From the VA, I just want you to know that Dr. Eads has been here with us all day. Am I saying your last name right? Okay, very good. And someone else who was here this morning was Dr. Marie Bernard, who's the deputy at the National Institute on Aging. And I believe we had some other NIA staff who were going to stick around. She said they were doing a medley relay kind of for NIA today. But I called her, invited her a couple weeks ago, and then told John. And I know she has provided, and NIA has provided a lot of funding. So this is a good federal team that we have. I, rather than sort of summarizing a day that we all sat through, want to maybe add some pieces that weren't discussed just to provide more context and information to the group as we move forward. First of all, Peggy, thank you. Thank you for your own career and professional work in this space, but then as a family member for sharing your story with us today. I think of this work in concentric circles with the person at the center and their family. So thank you for being that person for us today. It's a very grounded and grounding experience and is really the North Star for all of us. So I just want to say thank you for being that voice. It's where we all have to come back, So I want to thank you. And we talked this morning about the need to raise public awareness, and I have great faith and hope that we can activate legions of caregivers around the country who can help us do this. As I do aging and disability work, I often look to, as an example, of the power of caregivers, I look at what parents of children with intellectual and developmental disabilities demanded. We want our children in school. We want education for our children. We know what families can do because we've done it for the children in our country who were forgotten or set aside or certainly not provided basic education. We need caregivers to do the same thing for ourselves and for the elders in this country. So we need to figure out a way to activate them. I don't know what I can do about regaining the trust with the medical community, but that certainly was a major part of what we talked about this morning. In my sense of concentric circles, I always think about the person and then the community. And there has been a thread of discussion this morning and this afternoon about technology. And I agree completely with, where's Mike, who was talking this morning about technology, that the gaps that we have in some of the integration really starts with the lack of infrastructure that we have in community with regard to technology. I believe, Joanne, that we need care planning, and advanced care planning is a part of that. And I think care planning starts in the community as we start to provide more supports for people as they have functional limitations, and we involve the family and the whole kind of constellation of support. But we have not invested in this country in any sort of infrastructure to build information technology to that point. We have a new director of the Office of National Coordinator, Karen DeSalvo, who just started. We have talked, and I had talked to Farzad Mastashari when he was there, that in the meaningful use era, we're ineligible as community providers. So we're actually not allowed to connect. So it's not even like we forgot. We didn't allow it. So we all need to do additional work to talk to ONC about the fact that if we want seamless technology to help stitch some of this together, we need to revisit what meaningful use is and really talk about the fact that we started in the expensive places like hospitals, which is logical, but what our work is incomplete. So there's more to do on technology. We also, Joanne was talking about community resources, and I would be a completely remiss Assistant Secretary for Aging if I did not point out what has happened to the Older Americans Act. The Older Americans Act and Medicare and Medicaid are the same age. We will be 50, all of us, next year. The trajectories of these programs are astronomically different. When I got here, and I haven't pulled recent data, but when I got here, my annual budget for the Older Americans Act programs, the in-home services, in-home supports, meals, transportation, my annual budget was what we spend in this country on Medicare in one business day. That's what's happened in 50 years. The first 2 years I was here, the president recommended a $100 million increase, both years in a row, in our budget. Neither of those passed. We did, however, feel a sequester, where we cut $92 million out of direct services to older adults and their families in this country. That's a $200 million swing from where I was hoping to be when I started. So if we are going to kind of rise to the occasion and really capitalize on the ability and the willingness of communities to help in this integration, help be a part of the palliative care team, the advanced care team, we have to make the investments that we've not made, and we need to be aware that there's no automatic funding. These are discretionary programs, and they're critical. One of the results of reorganizing to the Administration for Community Living is that we have aging and disability working together in collaboration in a way that's never happened before, and it's been just a very positive experience. There's an even larger gain from doing that, and that's the fact that the Department of Health and Human Services has staked this claim, that HHS is saying we value as an objective supporting people with disabilities and older adults so they can live in their communities, and that's where they should participate. So we have been engaged in a strategic planning process since the beginning of last year. John Blum, who's the head of, may I have some just water? And so I won't go on forever, but you didn't know whose water that was, I could tell. John Blum, who's the head of Medicare, and I co-chair this initiative on behalf of HHS. Thank you. And we're putting together a community living strategic plan and putting together a document that we can push out publicly. One of the main objectives is to figure out how we can provide more guidance on what a comprehensive long-term supports and service system should look like in the states. And as we began to do this work, the issue of quality rose to the front immediately, because there's various aspects of HHS from the work that we're doing at the NIH, but certainly with AHRQ at CMS, where we recognize that if we're going to continue to support community services, we need a different way to evaluate them. And you should think of this as hand in glove with what we did with settings. If we're going to talk about person-centered planning, and if we're going to value this, if we're going to talk about palliative care and what a comprehensive, holistic support looks like, we have to have more than the clinical measures that we developed in this country. We have to talk about social inclusion, person-centeredness, self-direction, isolation. I mean, there are some different kinds of measures that we don't actually have. So we have been, and this came forward from all parts of HHS as a critical issue that we could work on together as a result of this strategic planning. I had the opportunity to meet last week with Dr. Christine Castle, who's the new director of the National Quality Forum. I'd met her on the phone during the snow day in December, and I told her when she sat down, I said, I just met you, but I love you're a geriatrician, because I know intuitively as a geriatrician you will understand the critical need for community supports and family. So I encourage all of us today who've heard this issue with regard to quality to think about NQF. We are directly engaged in conversations with them about how they can help us create a landscape for what we should be measuring. Take a look at the emerging practices that we have now, because we have a whole country, half of the states moving to managed care without good guideposts on what we should be looking for in terms of quality. So it's almost, it's not too late because we still need to do it, but it's happening as we speak. And so I would just, those of you who kind of talk today about quality from the clinical side, help us make sure that we don't lose track of good clinical quality measures, but that the quality of life piece is not there, and that we have to develop this together, and NQF is where we're starting to look. Then just as we continue to talk about supports across settings, I think we just have to all continue to figure out how to be translators, and that's what I see you all as being. I want to share with you, and then I really will wrap up, a couple of specific conversations I've had with medical doctors. since I started. One was someone who, as a colleague at HHS, who has not been here today, but a doctor at HHS. I was talking to this doctor who was a high-ranking person at the department about the Area Agencies on Aging and the Older Americans Act and what we do, and doing a basic frame for this doctor. And I got about 20 minutes into the conversation. He said, "Oh," I finally caught up. "There's a law behind you?" "Yes." "Oh, I always saw you as those free people out in the community." This is a colleague. So we spent more time and got through the conversation. And I said, well, first of all, yes, that's me. And no, we're not free. I mean, that if we want community services, and so for those of you that are doctors, I will say sort of as a colleague with a friendly challenge, doctors don't know about community services. And this other realization came to me when I was at a large teaching university hospital in this country, talking to a doctor who specializes in Alzheimer's. And he was talking to me about the people that he's studying who are living in community, and I thought, he thinks he's doing community work because his patient's living in the community. I wonder if he really knows about the community outside of this one patient or his group of patients, that there's a whole range of supports in community-based organizations, and the medical community doesn't know what those are. So I hope that as we advance this cause of advanced illness care and palliative care, that those of you who know what we do, those of us who know what you do and what you can add, can help be the translators in this country to talk about a holistic approach to care, that it's really about a person, it's really about them and their family and their home. And I think it was just wonderful that we ended by talking about home. That is just kind of, I thought, well, we could end right there. We could have all stopped talking when Phil, are you still here, Phil?
Yeah,
Phil, thank you for talking about home. I mean, I think that brings it all back. It is the mission of the Administration for Community Living. It's a core strategic plan for HHS that we support people in their homes and communities. And I'm going to end and try to be as possibly corny as I can be, because we have subjected you all to celebrating Kansas Day. Did you get that? We were surrounded, and Monty in his kindergarten, you should go, because I went. One of the last things I did when I was secretary is went to the kindergarten graduation with Kleenex. It's very moving. We get home, at home. And you were quoting a great poet, talking about home. And what did I do? Think stereotypes. I leaned over to my staff and said, Dorothy knew that too. Yep. One more corny Kansas thing. You already know the state song. Yes. Home on the Range. So thank you all for being here today.
I don't think I can top that. I will tell you that when she asked me, how will you know what success looks like, when we were talking on Monday, and I started with a response about more relief than anything. I said, well, have a video that we can get out to everybody. And she said, no, John, get out of the weeds. Get out of the weeds. I want you to tell me what the vision is. And I said exactly what Mike McGee said to her, right? That's what I said. Not really. I could never say what Mike McGee said. But I did say that the three most important things that seniors, regardless of where they are in their health status, is that there are three things that are most important to them: independence, quality of life, and functional status. Those are all relative terms throughout the course of their care. And all of those things matter. And that's what we're about with palliative care in terms of making that happen. I will say, though, that when I got off the phone after that and said, at least I answered her question, I thought of my mom, because I said, that's really the vision for me. My mom took care of my dad for 26 years at home. And 4 days before he died, he ended up in a hospice inpatient center. Now, my dad worked at a nursing home. That's what he did for 26 years before he got sick. And he stroked at the nursing home because they were building a new one, and the nuns wouldn't let him hire a second person, and so he ended up killing himself in the process, practically. Anyway, so she cares for him for 26 years. Her choice now, and that was her promise to him, was she would do everything she could. And 4 days before he died, he ended up in the hospital. A good friend of mine, who was a college classmate doctor, looked at this wound on his leg, and he said, that wound's not going to heal. I was about 2 miles from here at my office in Washington, when my sister calls me and says, Mike just came in to see Dad and said, this wound's not going to heal. And I said, finally, somebody has said something I understand. I said, get him the hell out of the hospital, get him into the inpatient center, and let's let him go. So they did, and 4 days later he died. My mom comes to me and she says when I go home, to be able to say goodbye to him, I missed it, but, with the funeral and stuff, and she said, you never told me you ran a hospice inpatient center like this. This is absolutely wonderful. You never talked to me about this. And I said, well, Mom, it really never came up in conversation, about Dad, because we just didn't know how sick he was, which was, here I am, a hospice director, and don't know how sick my dad is. But throughout that course then, she, we had our ups and downs along the way, but palliative care was really what she provided him the whole time. What her goal now is, and she's made this very clear to all of us, that what she wants as her goal is to be carted out of that house in a coffin. So our promise right now, for my mom, is to make sure we can do everything in our family, because this is very personal and about home, is to cart her out in a coffin. So thanks for coming and safe travels.